Good afternoon to distinguished delegates of this World Conference on Stem Cell and Cell Technology. I am really intrigued to hear since yesterday to James Sally, who gave the keynote address of the stem cell technology, how it is the driving force throughout the world. Now, he gave many directions why stem cell technology is going on. I am a clinician, I am a surgeon. Now, we are discussing the nuts and bolts of the technology here. Many of the scientists are discussing the basic forum. But what I got a stimulus from different publications, from different therapeutic applications. So being a surgeon, I was interested to apply this technology directly in my clinical practice. And in few minutes, I'll be showing you what I did and how this technology is really going to take off in future. I have done a basic level study, but there are distinguished people here who can take the technology to a very, very high level so that it will come back to us to benefit the common man, the suffering man, the end-stage disease problem, end-stage liver disease, end-stage renal disease, end-stage hepatic disease, end-stage heart disease, and brain disease. We have many, many end-stage diseases which we have no control. The way in which we act in a given situation is more or less influenced by the mental images that we have of the past. Now, to act in a very intelligent way to solve a problem needs careful study and observation, sometimes taking recourse to complicated statistical and analytical methods, which is available in other fields of medicine. But the statistical and analytical methods of Professor James Sally told us yesterday in his keynote address is not yet available. But we are trying to drive this technology high up because it has potentiality. Now I will show to these distinguished delegates just now what is this potentiality. At a basic ground level, I am not flying level 40,000 feet above. I have listened to talks of 40,000 level, which is beyond the limb of my understanding as a clinician. Because I don't go to molecular level of how this stem cell is working, how it is modulating, how it is having paracrine effect, how it is talking to the neighboring cell, how it is getting recruited there. This is beyond my capacity as a clinician, as a basic scientist. But you have the capacity and you have proved it, and I have been observing it. So thank you for your, then I will go to my next. This is the institution where I am working as a professor of surgery. I do a lot of clinical practice. Now my topic in this is foot ulcers. I get a lot of foot ulcers in my clinic because of the refractory. They don't respond to any conventional treatment available. What is that conventional treatment for any ulcer? Now we know as clinician to debride, to trace and treat the disease. If it's diabetes, control diabetes, but ulcer doesn't heal. Patient lands in amputation. There is sickle cell disease. Patient continues to have sickle cell disease, develops foot ulcer as a complication of the sickle cell disease. The ulcer doesn't respond to conventional treatment. And similarly, peripheral vascular disease, particularly Berger's, and where there is obliteration of the distal vessels. There is no bypass procedure possible. There is no drugs available. What can you do? And suddenly, we have this technology in future may help us in solving this problem. So I had tried at a basic level to solve these problems of arterial, venous, neurogenic and metabolic ulcers, which are refractory to treatment even with the best available treatment today, even in the United States and Europe and other developed countries. They are also facing the problem. I'm sure. When clinicians are there, they must be knowing. Now, with that, I'll show you one video clip. Now, we know all stem cells. Now, the material and method that I took, clearance of the Institutional Ethics Committee for applying the cells. Then a thorough search of literature was done. Informed consent of the patient was taken, and bone marrow was harvested from the patient's own bone. I preferred sternum because it was very easy, superficial, and I could give local anesthesia, antiseptic inside theatre. I could aspirate, I can use iliac crest, but I prefer sternum. The harvested bone marrow was then centrifuged with buffered fecal medium. This is called density gradient centrifugation. When you centrifuge the cells, they collect according to the different gradient of that, and this collected bone marrow from the density gradient cell. In this way, you find this one. With the medium, you will find this mesenchymal cell, this layer. Erythrocyte there, granulocytes here, the media is here, and the cells, mononuclear cells are there. I will have the videos, I can show you, they are not opening. Now, you know, diabetic ulcers is a chronic systemic disease which involves almost all systems, lead to neuropathy, microangiopathy, causing ulceration, even after minor trauma which refuses to heal. Ulcer is prone for delayed healing, non-healing, chronicity, and even lead to gangrene. And sometimes if you put a graft, skin graft, it also helps. So recurrence is very common and limb loss is very common. Now, that video patient that I was saying is this one. He presented to me with this state, already lost 3 toes, only 2 toes are there. This toe is going to fall up. Then he was desperately trying, sir, please save my limb. He was a worker, field worker. I told, okay, if you agree, I have a technology, I can apply your own cells to those areas which may help you. We agreed. I took the institutional ethics committee clearance, and then after a week of application, I found the good quality granulation tissue appeared there. And after about 4 weeks, this happened. The tissue started growing. The granulation tissue filled up the ulcer area, and after 6 weeks, we find this is the state. So I thought something is working there. He was not healing patient, running from patient to patient, from doctor to doctor. And then I applied in another patient. This was when he presented to me with this condition, SLAP, uncontrolled diabetes. I controlled the diabetes, debrided the ulcers, and applied the cells in a similar method. His own cells harvested, centrifuged in density gradient centrifugation, and applied the cells in the theatre directly to the margin, to the floor, to the base, and I found it's healing very rapidly. The quality of the granulation tissue appeared and it healed. One patient underwent amputation because it was gangrenous toe, and that portion, stump, was not healing. It was refusing to heal even after amputation. What we did, we applied the cells, his own cells, and we found that they also started healing. It is contracting. So what is that is contracting? The myofibroblasts are probably acting, and that needs a cellular study. How these are also the granulation tissue are coming very quickly. In 48 hours, this is my result. The granulation tissue quality, which was looking very pale, and this was appearing very red. And what is that? Means budding capillaries are coming. Neovascularization is taking place very, very quickly. Why it was not happening before? In other patients and in comparative patients I did not find that the granulation tissue quality is not improving. And then I applied in sickle cell, in the area of the institution where I am working, the sickle cell belt unit of India. That area, sickle cell. Now, you know sickle cell is an inherited blood disorder. Now, that has RBC with a defective hemoglobin. It affects globally. The patient is having also develops leg ulcers because of this crisis of the capillary block in the lower limb because of anoxia in the lower limb. There is more anoxia than in the upper limb. So in the anoxic conditions, they go into sickling and develop ulcers which refuse to heal. So this is a patient who presented with a sickle cell ulcer in this stage. Then after application of the autologous stem cell, I found good quality granulation tissue, and the epithelium is migrating very quickly from the margin towards the center of the ulcer. You can appreciate this migrating epithelium. So epithelium is migrating. Epithelium are spreading quickly. What is causing? The epithelial growth factor must be there. Some factor is definitely accelerating the epithelialization. And it healed around 6 weeks completely. I have not given skin graft or anything here. Now I found another patient, bilateral leg ulcer with sickle cell disease. Ulcer this side, 2 years, young man, 25. Nobody is willing to marry. He cannot go to work. No conventional treatment of dressing department. He is having a bandage, always working with a bandage, and friends asking, why you are having bandage? So like that, suffering. And then I debrided first I made debridement. I cleaned these dirty tissues called slough. And after debridement, this look like this, clearing the dirty tissue. If you apply cells on dirty tissue, and they will eat away the cells, stem cells. They are also normal cells, so you have to clean the ulcer. And then, a week after application of the cells, stem cells, autologous, bone marrow derived, still there is little slough here appeared. Or this was a healing. And then, after some time, I found after 4 weeks, this limb completely healed, and this is healing. You see how the epithelium is migrating, and this epithelium is coming, and this portion, and ultimately healed. And the same is venous ulcer. For varicose veins, you have surgery. You can do Trendelenburg operation, puppet ligation, you can do laser ligation. But for deep vein insufficiency, chronic venous insufficiency of deep veins, where you don't have any surgical facilities available till today, what you will do? So they develop ulcers, they develop chronic venous hypertension. You cannot do bypass, you cannot replace those veins, deep veins, femoral vein, popliteal vein, soleal venous flexure. You cannot do a graft, or you cannot take like heart transplant, kidney transplant. You can transplant those deep veins. Yes, we can remove the superficial venous dilatation, we call varicose veins. We can remove, we can sclerose, we can ligate, we can thrombose, but not the deep veins. So those deep veins developing ulcer, we don't have any facility. And that, you see, I applied the cells. The chronic venous, he has no varicose vein, but he has chronic venous hypertension. Picture of swelling, pigmentation, ulceration. These are the signs of chronic venous hypertension. And it healed after 6 weeks. So this is the serial photograph that I have taken. You can see it is setting sun, like it is setting, the ulcer is healing very nicely. And the cells, that means something is working. Then in peripheral vascular disease, as Borges disease and inflammatory disease of artery, nothing is available with us. We can't go stent, we can't bypass, because peripheral, arterial, digital, medium size, small arteries are affected by inflammation. So patient gets rest pain, severe rest pain, cry. This patient was trying, sir, I will commit suicide. I cannot tolerate the pain. The toe is gangrenous, smoker for around 40 years, smoking for last 20 years, and developed this gangrene. And critically ischemic limb, having 3 criteria: ulceration, gangrene, severe rest pain. Rest pain means night pains, cannot sleep. Everybody enjoying their sleep. He sits and catches the foot. No medicine, no antibiotics, nothing can help, no stenting, because the disease is vascular, digital vessels are affected. Medium sized, this is a posterolateral, dorsalis pedis, and tibial, anterior tibial, these are affected. So I applied cells. This girl developed a digital gangrene. So what I did, I applied the cells and found it restricted the spread of gangrene. The line of demarcation appeared. So certainly stem cell cannot regenerate now the dead ones, but it can limit the further spread of death or necrosis or gangrene by its effect, which you are doing. What are the effects? How it is working molecular level. So that is very interesting. And I applied stents in Hansen's disease. You know, this is a disease of neuropathy because of a bacteria. Repeated trauma, loss of sensation leads to ulceration, refuses to heal, and neglected by family. Nobody wants to approach because there is a feeling that leprosy may jump to attendant. So you are neglected in the family and brought by one of the medical student of mine, sir, please help this destitute lady. So I thought, okay, I'll apply. I debrided the foot. You see, the 2 toes only remaining, all toes are lost. And the plantar side, you see, the ulcers. After cell therapy, it started healing, showing good quality granulation tissue. And then you see the same 2 toes and it healed. And of course, I applied in severe burns involving joints, and about this patient I lost. Patient she did not survive. She died after the cell therapy, not because of the cell therapy, but because of the extensive complication of the burns. She had extensive burns elsewhere. And she succumbed to septicemia and burn complications, not because of my therapy. So no adverse events occurred during harvesting and application of bone marrow. There was evidence of faster healing of ulcers by appearance that I showed you in these slides, of healthy granulation tissue within a short period of time, 48 hours. This needs careful study again at a basic level. Why healthy granulation tissue are appearing? What are the factors that are influencing neoangiogenesis? We have a point there. And reducing the size of the ulcer and rapid epithelialization, we also need a study. So chronic limb ulcers are intractable conditions. Low quality of life and morbidity persist in this. Neoangiogenesis is a novel method of treatment, and vascular endothelial growth factor and fibroblast growth factor probably elicit the neoangiogenesis. Stem cells have immunomodulatory effect that we have now listened to many speakers. They act by differentiating into cells that are damaged, having paracrine effect probably by secreting growth factors, and they produce a sort of biological bypass where technological bypass is not possible. They produce biological bypass, I can say. Anywhere we need a bypass surgery, perhaps they will produce biological bypass. That word I can use. I have coined here, biological bypass, where technological bypass by stenting, grafting, or whatever may be the technique, not available. Ulcer healing in these conditions of diabetes, peripheral vascular disease, sickle cell disease, remains a challenge throughout the globe. Understanding and correcting the underlying pathophysiology also remains a challenge to us. So developing modalities of therapy to improve healing by cell therapy has shown great promise in my study, but needs collaborative and other center study, so that it will probably be the answer in this intractable problem. Thank you very much for your attention. Thank you. Yes, sir.
So I'm curious to know how the cells are being applied. Are they being injected? Are they being put on as a... how are you applying the cells?
Thank you, sir. It's a very interesting question that I wanted. I wanted slides that it's not opening up. Dhanya, can you help me? Are you there? She is my daughter-in-law. She works in California as an IT engineer. So, can you help me? Thank you. This is the ulcer. I saw the next one. He is asking how I applied the cells. The second one and third one. So this is the way I harvest the cells from the sternum. I give local anesthesia, and with a bone marrow needle I aspirate. And then prime that with heparin. That syringe is heparin, primed with heparin, and transmit into heparinized vials. The third one, Just show me the third one. I apply, after centrifugation, I aspirate the mononuclear cells and apply to the ulcer margin and to the floor to the base. This is the This is the mononuclear cells. We are injecting through the margin of the ulcer. 0.1 cc, 0.1 cc like that. And then we apply saline dressing. We don't apply again ointments and hydrogen peroxide or betadine. We don't put. We put only saline dressing over it. And we apply to the interdigital cleft, the wave space, then the floor of the digit. Little, the same 10 cc of this diluted with phosphate buffer. This American cells diluted with phosphate buffer. Can I show the pictures again? Come to the slide point. PowerPoint. Picture last. Back out more to diabetic foot. That's right. Now this is the picture after application. The same patient as you saw. And you see, this is healing. The same patient I showed you, the practical. And then this healed up. I have not sutured it by any suture or any graft I have not put. And the plantar side, you may be thinking I have done something to plantar side.
So have you tried this procedure with cells from another person?
I have tried cells with another person. With diabetes, I showed you second patient.
But these are all autologous, so it's the patient's cells from the sternum into the patient's ulcer. But have you tried sternal cells from another person to help?
Sir. I have autologous. I have tried. I have not done a heterologous application. I have not done. No, sir. Because I have no facility for storage, no facility for culture. Okay, I am a clinician. I have to take, this is the ground level, sir.
Well, I don't mean any culture, just directly.
Directly, no, sir. I cannot apply from because this will may cause reaction. I don't know. Autologous I have taken. This is when ethical committee doesn't permit. And I have a national body, Indian Council of Medical Research, it even doesn't permit autologous cell application. I have done my interest because your keynote address, yesterday I was talking to you, the driving force now. When I read literature, I see internet, I see some sensors are working. So autologous cells, I am giving my patients blood transfusion, that is heterologous. It is accepted universally. But stem cell application is not accepted universally, not regularized. We have no law now that we can apply heterologous cells. So I have not applied, sir. Thank you for a good question. Yes, madam.
Is it a single application in each case?
No, madam. In this patient, I applied twice because the ulcer size was big. But that gangrenous toe, I applied only once. To sickle cell, I applied twice. So at the interval of 3 weeks, I repeated.
Here is two questions. The first one is, what other concomitant treatments you have for the wounds? So I mean, you continue with the treatments, with everything conventional, and you just apply the cells.
You see, local care, regional care, and global care. This is the philosophy a surgeon manages for an ulcer. Local care of the ulcer, regional care means improving circulation, taking care of the joint, nearby joint, and immobilizing the patient. Local care means dressing. So dressing not to be done with any antiseptic, not to be done with any ointments, only saline dressing. First dressing to be changed after 36 hours because you want cells to adhere, to work, to talk to each other, or there to have paracrine effect. If you are changing on the next day, probably the cells will be washed away by your dressing solution. Dressing solution means normal saline. I use normal saline, no other chemical, no other povidone iodine, no Listerine or any other antiseptic, no hydrogen peroxide. It will damage the cells. So only cell protecting, cell encouraging solution to be put. Phosphate buffer solution you can put. You can, but normal saline is easily available in the hospital ward. So use normal saline. And we use antibiotic systemic care. We improve the anemia. If the patient is having anemia, hemoglobin is 6, I have to give blood transfusion. If the patient is having protein less, I have to give protein supplementation. I have to give vitamins. That is continuing. But local therapy, even if with in the conventional method of treatment, what I compared, even if you give blood transfusion, even if you control the diabetes, even if you give vitamins, even if you do dressing and debridement with antiseptic and ointments, the ulcer granulation tissue are not coming. The ulcer is not healed.
Okay. And the other question, is it happen that you measure anything in your samples? After the extraction, after the aspiration, did you measure any?
Yes, I had sent the granulation tissue quality for histopathological examination. I had sent the the material, that is the secretion, before applying the cells for culture sensitive, but the bacteriological assessment. It should be free from MRSA and Staphylococcus, Streptococci. It should not be there. When it is free from those bacteria, I do apply cells. No, sir. I gave just verbal anesthesia. I don't give any local anesthesia also, because the needle size is 23, 24. Sometimes I took this insulin syringe of the patient person takes insulin. Same syringe I take and load the mononuclear cells and give little to the insulin syringe. It is very much painless. But for harvesting the bone marrow, I use local anesthesia. But for injecting the ulcer site, I use insulin syringe. This syringe I showed is a 22 needle size, very thin. Patient tolerated well, you have seen. It is no anesthesia.
They're very nice qualitative results, but would you describe this as an observational case series rather than a
Yes,
a
I'll do
study?
that. I'll do a number of series. I request you please go back to your hospital and apply, and let us have a collaborative study and collaborative and comparative study. What is your finding? My finding. So
Because you need some negative controls where you've got patients that
is what I am telling.
you're
Negative,
injecting something
I
else
applied
or-
another cells to other patient where I did not apply cells. They did not respond. They lost the limb. They lost the digits. That is my experience. I am telling from my experience. But next session in 6th World Congress, I will bring that study, that how I lost the digit there and how it is giving good result. And I request you please go back to your hospital and have this study and then write to me, and we will have a comparative statement. Okay? Yeah, control.
Can I ask one more question? With the cells that you isolated from the sternum, did you do any phenotyping for those cells to show
No,
they were
sir,
MSCs?
no. I did not do any autologous bone marrow derived mesenchymal stem cells I used by density gradient centrifugation method. The way the density, the media that I use is fecal media.
Sure.
Lots of interest. So, do you need to do the FICO separation? If you just take the cells that are removed and apply them, is the separation important for what you're
Very
observing?
interesting question, sir. That is my practical application. I harvested sometime this fecal medium is not available. So what I do, I aspirate the bone marrow and I had injected to certain ulcers, and I have found good result. Even simple bone marrow application, direct application on the table, aspirate, inject the bone marrows, and that also has certain concentration of bone stem cells. That is a good question Professor James Shirley has raised, and that is my personal experience. I harvest the cell from the bone marrow without separation, I inject it to the ulcers, and I have got good results. And I can show you next time my finding.
Is there any difference in the healing time when you do the whole bone marrow versus isolated cells?
No, madam, the healing time is same, and granulation tissue appearance, good quality granulation tissue appears within 48 hours, even with application of bone marrow, madam. This is my statement. I'll show you in the next session in San Francisco. I was talking to our president, Professor Sudhakar. He will conduct the World Congress in next session in San Francisco. My children are there. I'll definitely come. I'll meet Madam Paleniu and Professor James there also, I hope. And I'll show that direct application of bone marrow aspirated from the patient's autologous, what effect is it having on the ulcers. That I will show in next meeting. So we can have a therapeutic effect.
Have you tried also adipose?
No, sir. I have been associated with the National Institute of Technology, Rourkela. They are Department of Biotechnology, having a full-fledged laboratory of stem cell technology. They have been requesting me to supply fat cells so that can isolate. But then regulation doesn't permit. My institute director doesn't permit me. And the regulation is say you have to take national body permission. And this meeting I am been fighting, this is working, not bolt, I don't know. I want the vehicle. I want vehicle. Why you are pressing me being bolt? I want a vehicle to travel and cure my patient. You are telling me where is the nut, where is the bolt, where is the steering wheel, where is the tire? I don't know. I want adipose tissue and give. I say, will give me stem cell of the autologous. I will say, no, not permission. You have to take national body permission for giving adipose tissue, for any tissue to any other institute. You have to take permission. So there is a nut and there is a I told driving force. He told in keynote that is the opposite of driving force. I said a blocking force. There is some blocking force somewhere. So it is not possible to transmit adipose tissue to some other institute for isolation, separation, culture, then again transmit from that institute to my clinical practice, translation is very, very difficult now because of the legal problems. Am I right, sir? But they have been pressing National Institute, people, please give us adipose tissue. We'll give you cells. Yes,
So,
sir?
I just want to make a comment. I'll just say a priori, I don't think that adipocytes, whatever's there is going to do what's happening here. If we think about what goes on in human physiology, when I get an injury to my finger,
Sir.
there's a whole system that creates a granulation tissue. All that happens because I have blood flow.
Yes, sir.
And I think what's happening here is you're taking those same components and putting them where they can't get to. Makes good sense to me.
Well, I've heard in other stem cell meetings, as a matter of fact, in Miami back in last September, International Society of Plastic Reconstructive Surgery, and a lot of international speaker and presenter. What it is mostly reconstructive surgeon and stem cell practitioners. So several actually presented from Argentina and actually China and also in India. They're using adipose, autologous,
Yeah.
and as they use, and they have really good result. Not only that, particularly burn patient.
Yes, yes. Why
So,
they are using adipose tissue?
There's no question mesenchymal
Yeah.
cells works.
Yes, yes.
So
The concentration of the stem cells are more in adipose tissue. They are in bone marrow, they are telling.
Definitely.
I don't know the statistics, but they are saying if you harvest adipose tissue, then separate the cells, the quantity of cells that you get, stem cell, is more in adipose tissue. I don't know.
and in fact, adipose is more stem cell count-wise compared to
Okay.
bone marrow, and it's a lot even safer. And actually, I'm doing right now a clinic using it for my interventional pain procedure, spinal, and I'm using adipose stem cell. I used to do bone marrow, but now I convert to adipose stem cell because of I got better results. Actually, I'm talking about pain practice. I've got better results with the adipose than the bone marrow. So just a thought.
Thank you.
And Dr. Shirley, to your comment, it's not just blood flow. It's not likely to be just the giving the blood components, because in this country there is a lot of usage of amniotic membrane, both desiccated and fresh amniotic membrane, to diabetic foot ulcers and also venous ulcers, and it is showing excellent results. So that is not a blood component, but it is cells, which are there, stem cells which are there in the amniotic membrane.
And then they will be heterologous, madam, not autologous.
Yes.
And there is a chance of reaction more, and rejection and infection is more, because you are taking tissue. Here you are taking cells.
Actually, it's available now. Here it is. It's now available now, the placenta-derived amnion, which is not actually a stem cell, it's actually growth factors. And in fact, this one is manufactured actually produced in Florida.
Right.
But very, very expensive though.
Right. If it is desiccated amnion, we are talking only of growth factors. But if it is a fresh amnion, which is preserved in the medium, we are also looking at the cell viability, and that there is a cellular component here.
I mean, I think
Yeah.
that the basis of all this are the immunomodulatory properties that stem cells. So, I mean, I didn't make the presentation this morning, but tomorrow morning I hope to see all you there. And the immunomodulatory properties that are of mesenchymal cells of bone marrow, that are of amnion, that are of adipose tissue, I think are the ones that are playing the role here. So, so it's not only growth factors, but are factors that are doing some immunomodulation. And
Exactly, madam.
So I think it's a combination. As a matter of fact,
They are recruiting the local stem cells. These stem cells, when come here, somebody asked me why they are not going. If it is required in the body, why they are not going from here to there? They should travel and say, oh, my toe, you are in problem. Can I help you? Can I help you? But they are not traveling. So why are we transporting from harvesting and then culturing and then increasing their number and injecting, if it is possible in the lab? But for me it is not possible. I am just helping to transmit those cells to there. But then, as madam, you told rightly, they have immunomodulated effect. And those immunomodulated cells talking to each other, hey, here is a problem, come here and help us to building the blocks, the fibroblast, get activated. They are dormant in diabetics. Leukocytes are lazy. Leukocytes are very lazy in diabetics. They don't react. So when they go there, they secrete the kinins, the cytokines. Oh, get up. There is a problem. We need tissue. We need building blocks. We need collagen. We need granulation tissue. Come on. So that is probably the story. I cannot listen, but I am listening wonderfully. How beautifully you are presenting your papers in such a molecular level. I am really grateful to the organizer, Professor Sudhakar, and to all the distinguished delegates that they have their excellent papers. I am learning like a student. I am working like a laborer just to help some poor patient, but I am learning here like a brilliant student from you. You are all my teachers. Thank you, sir.
I just want to say that it makes perfect sense to continue with bone marrow and not go to adipose tissue, because
yes, sir, thank you.
With this protocol about doing centrifugation, the concentration of hematopoietic stem cells is more than mesenchymal.
But I am tempted by my collaborative institute, in NIT Routledge, engineering institute. They are pressing me, give us adipose tissue. Yeah. The concentration of stem cells are there. I am not giving because of legal problem. I am not able to give.
What I wanted to say is, you are doing in the simplest level, and if that level is working, so we don't have to escalate to placenta, to embryon, to adipose. In this level is working, and I think when we have results in this level, we can
what
keep
is the need
them.
of adipose tissue?
Yeah.
Oh, I will convey your message to my authority.
Okay, I think we have a very good discussion. Okay,
thank you.
We will end this section. Thank you for all the speakers, also the audience. Thank you very much.